Hello there, my name is Dr. Imran Sayed and welcome to this short presentation on an approach to non-diabetic hypoglycemia. Let's begin with a case study. So we have a 45-year-old female referred from the GP service who's experiencing dizziness, sweating, headache, particularly if she delays or skips her meals. She feels better after she's had something to eat. She doesn't have any significant comorbidities. No weight loss, no loss of consciousness. So given this short presentation, how do we go about thinking of this constellation of symptoms? So obviously we begin with a thorough history and examination. Particularly in the history, we'd want to elucidate the nature of the symptoms that the patient is experiencing. So the symptoms of hypoglycemia can be divided into two large buckets. You've got the autonomic symptoms, which may be palpitations, tremors, sweating, and these are usually due to the counter-regulatory hormones that are released during hypoglycemia, so hormones such as glucagon, adrenaline, cortisol. The other bucket is called the neuroglycopenic symptoms, so things like confusion, unconsciousness, and seizures. So what type of symptoms are they having? What is the timing of the symptoms? Do they happen at night, during sleep, during the daytime? Is there any relation to food? Does it happen after food? Does it happen in between meals? Do they have symptoms of severe hypoglycemia? So severe hypoglycemia is defined as an episode that requires third-party assistance to administer treatment. So the patient may have confusion, they may be unconscious, or they may have had a seizure, and you require a third party to give medication. Do they have any relieving factors like taking sugary drinks, having a sweet, having carbohydrates? Have they actually documented a low blood sugar during these events, during the symptoms? That's very important. And do they have any other symptoms associated with what they're experiencing? So weight change, skin pigmentation, and fatigue, which may point to another endocrine syndrome. Do they have any previous medical history or previous surgical history? Have they had bowel surgery done? Are they taking any medications? Family history. Do they have any similar symptoms in the family? Do they have any family members who are taking medications for diabetes at home? Social history. What's their occupation? Do they take alcohol? Do they engage in any recreational drug use? With these symptoms, usually the examination is unremarkable unless they have features of another endocrine syndrome such as adrenal insufficiency, but generally the examination will not be revealing. So what would be our differential diagnosis at this point? So many different conditions may cause or may predispose a patient to hypoglycemia. Of course, critical illness such as sepsis or acute kidney injury, hepatitis, cardiac failure, certain drugs, of course, drugs related to diabetes, but also alcohol and quinolones are notorious for causing hypoglycemia. Hormone deficiencies, so for example, adrenal insufficiency may lead to low cortisol levels, which can cause hypoglycemia, and a certain subset of what we call non-islet cell tumors, so tumors such as fibrosarcoma and hepatocellular carcinoma. And the etiology of causing hypoglycemia is quite interesting here, is because these large tumors secrete a hormone called IGF-2, insulin-like growth factor 2, which has a similar effect like insulin. It actually attaches to the insulin receptor and may cause hypoglycemia. And the final bucket here is what we would call endogenous hyperinsulinemia, which is uncontrolled hyperinsulinemia. And that can be due to an insulinoma. You may have autoantibodies in a syndrome called insulin autoimmune hypoglycemia. Hyperinsulinemia is very common after gastric bypass surgery. And finally, the very rare syndrome called non-insulinoma pancreatogenous hypoglycemia. So, how do we proceed in terms of investigations? So first of all, we'd want to establish that they do have signs and symptoms of hypoglycemia. We'd want to document a low blood sugar when they're having those symptoms, and we'd want to know that their symptoms resolve after ingestion of a carbohydrate. So this triad of this principle is known as Whipple's triad. It's very important to establish this triad before proceeding with investigations, and actually many endocrine society guidelines recommend that we establish Whipple's triad before investigating further, simply because blood sugar may be artifactual. Signs and symptoms of hypoglycemia are quite variable, so it's important to establish this triad before proceeding. So, what are the investigations that we would do? Basic chemistries are in order, so liver function tests, UNEs and creatinine. We may do a short synaxin test or a 8 AM cortisol to screen for adrenal insufficiency. It's important to do a sulfonylurea screen to rule out factitious ingestion of sulfonylureas. A fasting test is a provocation test done in patients with hypoglycemia. So what we do is the patient begins a fast, beginning with the 24-hour fast. They're allowed to take water, but nothing to eat, and we monitor their blood glucose. And if they have a hypoglycemic spell, at that point we collect blood samples for insulin and C-peptide, and especially if the blood sugar is less than 2.5 and the insulin and C-peptide are non-suppressed at that point, that pretty much establishes the diagnosis of an insulinoma. We would only do imaging after we have established a biochemical diagnosis. So if we've established that insulin is being produced unregulated, then we would go on to do probably a CT or MRI to localize where that would be. So the take-home points are: we would use the history to navigate the differential diagnosis. The questioning during the history is extremely important. We would establish Whipple's triad before investigating further. This is to avoid unnecessary investigations. And we would establish the biochemical abnormality before proceeding to imaging. So this actually is the central dogma of endocrinology. We must establish a biochemical or hormonal abnormality with dynamic testing, if required, before proceeding to imaging, and this is to avoid going down the rabbit hole of chasing incidental findings on imaging. Finally, in a patient with insulinoma, we'd want to consider if they have any other features of multiple endocrine neoplasia syndrome, particularly MEN1 syndrome, where you may have pituitary adenomas, primary hyperparathyroidism associated with pancreatic tumors such as insulinoma, glucanoma, etc. So that brings us to the conclusion of our talk. Thank you for listening. Here are the references if you need further details. Thank you very much.